So hi everyone. I am a psychiatric pharmacist. I am an associate professor at the University of New England School of Pharmacy, and I also have an adjunct affiliation with the Tufts School of Medicine in the Department of Psychiatry. I am core faculty along with Elaine O'Connor, Dr. O'Connor, in our Maine Medical Center Addiction Medicine Fellowship Program, which is the fellowship program for physicians who have completed residency and want to go on to specialize in addiction medicine. And as it relates to this group in this area, I am working on two related research projects assessing risk factors for postpartum psychosis. So that's one of the ways that I dive into this a little bit more. And today I'm really happy to be here to talk about postpartum medication issues, particularly postpartum medication use in someone who is chest feeding. I do want to acknowledge that language is always an evolution, and this is something that I'm working on evolving in myself is moving from breastfeeding over to chest feeding. Many of these slides do say breastfeeding because I have not had a chance to update those yet, so I want to acknowledge that. But I'm trying to move towards chest feeding as a term instead of breastfeeding to acknowledge that some people who do give birth and then go on to chest feed don't have breasts and or don't uh, identify as a man, and so therefore calling breast tissue breasts can sometimes be traumatizing for some people. So I am moving toward language of chest feeding, which really describes what it is, which is feeding another human via the chest area. Next slide, please. So we're going to dive right in with some evidence here and some data. So really thinking about what happens pharmacokinetically pre and postpartum. So we have a lot of changes that happen in our body when we become pregnant and then when we deliver. So during pregnancy, some big things that happen include an increase in total body water. That's really important, as well as an increase in blood plasma volume, and all of that's really essential to get enough blood through the placenta and to provide nutrients and other things to the developing fetus. You also have pretty large changes in protein binding, and that's going to directly impact how much medication is available to the body, because any medication that is bound to protein is not available to the body to bind to, like, I don't know, dopaminergic receptors, for example. You also have changes in muscle to adipose tissue ratio. So you have a higher amount of adipose tissue versus muscle ratio. And so that's going to increase volume of distribution for any medication that likes fat more than water. And most medications that are psychotropic, most medications that cross that blood-brain barrier are lipophilic. They're fat-loving medications, and that's part of how they facilitate crossing into the brain. Additionally, there's increased hepatic blood flow, so that's going to impact how medications are metabolized, and that's really complicated. We'll talk more about that in a second. And then also, you have increased renal blood flow and increased filtration, so that means clearance of medications go up. So overall, you have a bigger tank, right? So now you have more body water and more plasma volume, so a bigger tank for a dose to go in. Changes in the amount of available medication within that tank, how much is bound to protein or not, and then also changes in how much is eliminated and metabolized by changes in renal blood flow and hepatic blood flow. And then so all that happens during pregnancy. It kind of ramps up more into the second trimester and then continuing into the third trimester. And then after birth and the postpartum period, a whole bunch of other changes occur. And so some of those changes include a rapid decline in sex steroid levels. And that's actually one of the thoughts behind postpartum depression, the development of postpartum depression, are these changes in sex steroid levels. And that's actually not the scope of this talk at all, but ushered in a whole new class of medications, which are allopregnanolone analogs that are available. Brexanolone was the first one. You also have contraction of plasma volume, so it expanded during pregnancy, it contracts in the postpartum period. Those changes that happen in hepatic metabolic enzymes, so changes in cytochrome P450, say like 3A4, for example, we'll talk about this more in a second, as well as changes in the enzymes that do phase 2 hepatic metabolism, so UGT enzymes. All of those changes that happen during pregnancy normalize in a postpartum period, and you have a normalization of that renal blood flow. So renal filtration goes back to normal. So during this time in particular, there's a large risk for medications, if doses are not changed back to the pre-pregnancy dose, that patients may experience adverse effects. They may experience toxicity. And again, it's really important to consider this, especially if medication doses have changed during pregnancy, which is what's recommended for many psychotropic medications. Next slide, please. So a little bit more specific to antidepressants. So we know with antidepressants, all of those things impact, all those things we just talked about certainly impact antidepressants. We know with SSRIs, it's recommended that you increase the dose in the second to third trimester. And it's also recommended against reducing the dose pre-delivery. So it is recommended to reduce the SSRI dose after delivery in the postpartum setting back down to the pre-pregnancy dose, but it is not recommended to do this before delivery in an attempt to reduce neonatal symptoms. So the literature does not support tapering down or off an SSRI during pregnancy in an attempt to reduce neonatal symptoms that occur. That's not recommended. So it's recommended to increase the SSRI dose in the second or third trimester, keep it at that dose through delivery, and then reduce the dose at that point. SNRI recommendations are a little bit less clear, but if the dose is increased during pregnancy, then it certainly should be reduced in the postpartum period. TCAs, we have a little bit more evidence because we tend to do TCA blood levels because of polymorphisms and other reasons, and toxicity is another big reason. So we know that in general, TCA medications like amitriptyline and nortriptyline do require a dose increase. The magnitude of increase is going to vary from person to person and largely depends on, again, those genetic polymorphisms in cytochrome P450 2D6 status. So generally, if you have a person who's pregnant on a TCA, close clinical as well as close pharmacokinetic monitoring of TCA levels is recommended. And just like with SSRIs and SNRIs, if the dose is increased in the pregnancy period, it should be reduced back to the pre-pregnancy dose during the chest feeding period or during the period after pregnancy. Next slide, please. So some factors that impact excretion into breast milk. So there's two different sort of buckets we can think about. We can think about factors that are relate to the medications themselves and think about factors related to the person who's pregnant. So on the left-hand side, thinking about factors related to the person themselves, how much something is ionized or not is going to matter because if something is ionized, it doesn't cross as readily from sort of one area to another. So the amount that something is ionized or not is going to determine whether it's going to more readily or less readily excrete into breast milk. And that's going to be very specific to each very specific medication. If you talk to a pharmacist or a pharmacy student and you use the three letters pKa, you might see glassing over, but those are things we have to learn about is the pKa's of different drugs. And then depending on what the pKa is, that's going to determine how ionized it is in a given physiologic pH. So that gets really complicated really quickly, but the bottom line is depending on if it's ionized or not will determine whether it excretes or not, and that's very specific to the drug. How big the drug is it have a high molecular weight, it's really big and bulky, or a lower molecular weight? That's going to determine if it's easy to cross or not cross into breast milk. What about the kinetics of the drug themselves? So is the time to peak plasma concentrations really quick? Are the peak plasma concentrations really high, or is it kind of a more smooth pharmacokinetic profile? And then also, what is the milk concentration versus breastfeeding time? So, and peak plasma concentration time. So for example, if someone takes a medication and their peak plasma levels occur in like 1 to 2 hours and they breastfeed, maybe 10 minutes after taking the medication, there's going to be very little amount of that medication that's going to cross in the breast milk, regardless of all these other factors. But if they're breastfeeding in that peak period of time, much more is likely to cross. And then also protein binding, that goes back to what we talked about. If something's bound to protein, it can't bind to receptors, and also it's going to impact its excretion into breast milk. On the maternal side of things, or the person who is not pregnant anymore, I guess the person who's delivered side of things, the person who's chest feeding, the pH gradient of the serum and the breast milk, that's going to vary slightly from person to person, and that needs to sort of be weighed against that ionization piece that I was talking about earlier. So depending on the pKa of the drug and the pH within the breast milk, for example, will determine if that specific drug is ionized or not ionized. And when I say ionized, what I mean is if it has like if we're talking about potassium chloride being non-ionized versus potassium by itself with the little plus being sort of ionized. Polymorphisms in different metabolic pathways. So cytochrome P450, 2D6 is a big one for a lot of psychotropics, including most of our antipsychotics, many antidepressants, and certainly TCAs, for example. And what we know is that some people genetically have much more extensive or robust enzyme function, and some people genetically have very poor or very slowed down enzyme function. And so that's going to determine how much of something is going to get into the breast milk. A classic example there, and the reason why codeine is not recommended to be used in people who are chest feeding is because codeine, there are stories and cases of people who were chest feeding and had a 2D6 polymorphism that caused them to be an extensive metabolizer, which means they metabolize codeine really well. Codeine is metabolized to morphine. So people made a lot more morphine, from their liver, genetically. And in some cases, that's led to poor outcomes, very poor outcomes in a chest feeding neonate, right? Because you can see signs and symptoms of opioid toxicity in that situation. And that's directly related to a polymorphism in 2D6 in the person who's chest feeding, creating more morphine going into the person who's receiving that feeding. Other medications the person is taking is going to impact excretion into breast milk, both medications that impact other cytochrome P450 enzymes or also dynamically. There's also evidence coming out about the impact of certain medications, such as anticholinergic medications, for example, on the production of chest milk itself. Also, the composition of fore and hind milk can impact excretion, as well as if someone engages in cigarette smoking or smoking of tobacco products more broadly. Next slide, please. So I mentioned we talk about the changes, specific changes in cytochrome P450s. Don't memorize this. I don't know if anyone's really memorizing this type of information, but it's sort of a reference for you to have. So at the top are the cytochrome P450s. These are the things we talk the most about. 3A4 is the one that's impacted in the vast majority of medications, which I learned recently is because it accepts medications that are much larger than 1A2 and 2D6. And so that's why 3A4 is more associated with metabolizing more medications, and that specifically is going to be more active in women in general, regardless of pregnancy. And then on the flip side, 1A2 is less active in women and more active in men, regardless of pregnancy. So with 1A2, I always think about the situation when I have a person who is a man who smokes, and they're going to have a much more active 1A2 function than a woman who does not smoke. And that's really important for drugs like clozapine, but also olanzapine and other antipsychotics. And then on the right, you can see what happens with pregnancy. So it's a little complicated because we can't just say some are induced and some are inhibited. It depends on the enzyme. So the majority that we talk about, though, are inhibited. So 1A2 has less function, 2B6, 2C19, and 3A4 have less function as well. Whereas some of the phase 2 metabolic enzymes, the UGTs that metabolize drugs like valproic acid, are actually induced during pregnancy. And so that's another reason why we have to think about increasing the concentration of the dose, which leads to correcting the concentration of other drugs in addition to those metabolized by cytochrome P450s. And then there's also differences that can be intensified during pregnancy, including slower gastric emptying and intestinal transit time too, that impact all of this. So there's a lot going on here. Oh, next slide, please. So, okay, so thinking about antidepressants and breastfeeding. So there's this this safety index that's been developed, the Breastfed Infant Antidepressant Safety Index, or BIASI, and the calculation is the number of infant adverse effects over number of healthy outcomes plus the number of infant adverse effects times 100. And so in general, when you're thinking about this and looking at this, a score of greater than 10 is considered to be contraindicated, whereas a score of less than or equal to 2 is considered relatively safe. And then a score in the middle of that from, more than 2 to 10 is sort of that gray area, that use with caution. And so looking at some of our common SSRIs that we use, you can see that sertraline has a really low BIASI of 0.68. So it's actually one of our drugs of choice, one of our SSRIs of choice in people who are chest feeding. Paroxetine also has a low BIASI of 0.95, making it also an SSRI that could be preferred in someone who's chest feeding. However, paroxetine is generally dispreferred in patients who are pregnant. And so we don't generally want to have someone on something during pregnancy and then switch to a different SSRI postpartum. So for that reason, even though paroxetine is one of the safer options for chest feeding, generally patients will continue on, say, sertraline through pregnancy and then chest feeding because it has utility and more safety in both of those periods. But paroxetine, sertraline, and fluoxetine have the most data. We talked about the mild short-term adverse effects with paroxetine and sertraline, and then some more moderate, severe short and long-term effects with fluoxetine, as well as both citalopram, racemic mixture, and the enantiomer, the S-citalopram. Next slide, please. So this is just a graphic depiction of what we just talked about here. And again, sertraline tends to be one of our go-tos because it is one that can be used more safely during pregnancy as well as during the chest feeding period. You can see a couple SNRIs on here, duloxetine on the left-hand side. We don't have as much evidence, but you can see it is one of the ones that does have a lower ratio here, whereas venlafaxine on the other side of the SNRIs has a little bit of a higher relative infant dose range. But again, that do not use line is 10. And so none exceed the do not use line, but many of them do cross or exceed that 2% line being in the gray area. Next slide, please. So this is a different scoring system. This is a safety scoring system for psychotropic medications and breastfeeding. The other one was just antidepressants specifically, where this is more broad to psychotropic medications. This is a 10-point scoring system. It's based on 6 parameters. So there's the total sample reported, and that can be up to 3 points. The maximum relative infant dose is up to 2 points. The sample size for the relevant infant dose, infant plasma drug levels, those are each 1 point. As well as serious adverse effects. And then the prevalence of any adverse effect is up to 2 points. And so taking all of those things into account, the higher the number, the more safe the medication. So it's opposite of what we just looked at with the other rating scale, where a lower number is more safe. Here, the higher number is safer. And so for safety profile, you can see there are a couple medications that fall in that 8.6 to 10, and that's sertraline and paroxetine again. Good olanzapine as well as citalopram with this rating scale and midazolam fall into the good section. Many medications we use in psychiatry fall in that sort of middle area, moderate section. Getting into low, you start to see a lot of our antipsychotics, particularly many of our antipsychotics that have impacts on, say, prolactin levels, which would be really important when thinking about chest feeding, for example. And then finally, there's a very low safety profile, according to this scoring system, for antipsychotics, including aripiprazole and clozapine, but also one of our TCAs, doxepin, and then a couple of our other sleeping medications, zolpidem and zaleplon. Next slide, please. So sertraline and breastfeeding. Sertraline is the safest SSRI for chest feeding. We talked about it has the lower relative infant dose and that lower safety index score, and there are low reports of adverse effects. There was actually one study looking at sertraline in infants who were breastfeeding, and that included 279 infants. They did find that benign neonatal sleep myoclonus developed, but then spontaneously resolved in one of the infants, so 0.4% overall. Withdrawal also did occur in utero in one infant, and that manifested as agitation, restlessness, poor feeding, and insomnia. Again, 0.4% incidence. There were detectable serum levels of sertraline in 3.6% of the infants and detectable levels of the metabolite norsertraline in 9.7% of the infants. The milk concentrations did detect sertraline or norsertraline in about a quarter of the infants, and you can see the milk to plasma ratio range vary quite a bit from under 1 to almost 5. This indicates that in some people, the plasma ratio or the plasma concentration was higher than the milk concentration, whereas in others, the milk concentration was higher than the plasma concentration. Next slide, please. Very briefly, lithium and breastfeeding. Lithium used to be absolutely contraindicated for breastfeeding. It's no longer absolutely contraindicated, but it is not generally recommended as sort of like a baseline. But there are definitely people where the risks of lithium are outweighed by the benefits, even in a situation of chest feeding. So it's really important to employ shared decision making, consider important benefits of chest feeding in the first 6 months against the risk of exposure to lithium in the infant. Overall, it's not recommended anymore to do pump and dump. So the recommendation is not to, take lithium, pump during the peak and then dump it out. That's not recommended anymore. So the decision is either the infant is exposed to lithium or they're not, because they're either getting chest fed or not, right? And so that's kind of the decision. No serious adverse effects were observed in the majority of chest-fed infants who were receiving lithium via chest feeding, but one infant did become dehydrated via an infection and did develop some lithium toxicity with a level of 1.4. And in adults, 1.4, 1.5 is sort of the cutoff where we think about toxicity. Generally, the upper limit of normal is about 1.2, just to give you a sense of this level. So that is clearly toxic, whether it's an infant or an adult. And that happened in one infant. One infant developed elevated TSH, which is a known potential effect of lithium. And then 3 infants, so 30%, did develop transient elevations in serum creatinine and BUN levels, so indicating changes in renal function, which is another known effect of lithium. So close observation and monitoring of the infant lithium levels is important. So not just that the person is chest feeding, but also the infant, the neonate lithium levels. So that does mean heel sticks, right? So that the neonate is going to be getting heel sticks, as well as infant thyroid and renal function. Those are all recommended. So these are all things that have to be part of that clinical decision making with the patient, the person who's chest feeding. And then if the infant levels accumulate or the infant develops any signs of lithium toxicity or any signs of renal or thyroid toxicity or abnormalities, then chest feeding should be discontinued at that point. Next slide, please. So here's a little bit more about lithium. In general, on the bottom here are some reasons or some situations where breastfeeding might be a reasonable option with lithium, including a stable mood of the person who is chest feeding, a person being on lithium monotherapy or a more simple regimen, a healthy full-term infant, and then adhering to all those specific guidelines. If you remember nothing about this and you want to remember something about lithium and chest feeding, remember the rule of halves, which is that the maternal serum level, if the maternal serum level is about 0.8, the breast milk lithium level is about 0.4, so about half that. And then the infant serum lithium level would be about half that, 0.16. So it's about half from maternal blood to breast milk to then infant blood. Next slide, please. And then antipsychotics in breastfeeding, there's much less evidence here. 37 reports in over 200 infants exposed to second-generation antipsychotics. And this chart on the right-hand side is not about relative benefit or not. This is how many exposures. And so you can see the vast majority of exposures were to olanzapine. And basically, overall, they found that there were low RID values for olanzapine, quetiapine, and ziprasidone. So if an antipsychotic needs to be used during chest feeding, those 3 are going to be less likely to pass into into breast milk and into milk that's getting into the infant. And then overall, they found that adverse events were rarely reported in infants exposed to any second generation antipsychotic overall, with the exception of exposure to clozapine, where there were more reports. Next slide, please. And then this is the final slide, just a little bit about patient education, because there's a lot here and we can't and probably shouldn't talk to our patients about all of the nitty-gritty here. That would just be really overwhelming. So what we can do is we can instruct people who are chest feeding to observe for signs that indicate the infant might be experiencing adverse effects of that substance. So that could be behavioral changes, that could be hydration changes or indication of poor hydration, indication of any kind of sedation or hypotonia, any kind of changes in feeding, especially poor feeding or slow weight gain, certainly any changes in, anything indicating hepatic impairment, like certainly jaundice, or anything indicating any kind of hematologic impairment, or blood value abnormalities or any kind of overt bleeding. And then finally, infant serum levels are not obtained routinely with most of these, except lithium. Lithium is really the most important one. And I would also say probably TCAs, maybe, but lithium is really the big one. An exposure can be limited by using the lowest dose, but the lowest effective dose. It has to be effective. Using as few drugs as possible to achieve the therapeutic response. And then also dividing daily doses to avoid those high peak serum concentrations. So some things that can be done overall, but a lot of it's about picking the safest medication up front. And that is what I have for you. And I